All right, so sometimes a patient will be placed on diuretics, and this is just a broad term for any drug or chemical that is going to increase water loss and enhance urinary output. And since we just discussed how we conserve fluids, a diuretic is going to have to somehow inhibit something, right? So some of them directly inhibit ADH, so antidiuretic hormone. Alcohol, I don't know if you've ever imbibed in that, but you tend to go to the bathroom more frequently. Others can inhibit the reabsorption of sodium, and we learned whenever we reabsorb sodium, that means, you know, that's where water goes. If we don't reabsorb sodium, we'll get rid of it. So if you've heard, like when someone says they're on water pills, like I said, these types of drugs can be given if somebody has hypertension, because we know if we reduce blood volume, we'll reduce blood pressure. If you like caffeine, the way caffeine, one of the ways it works is that it will increase GFR because it's going to oppose that vasoconstriction when things are high, so you lose more fluids. Loop diuretics, that has to do with, they are going to make the middle, the medulla, less salty, so we'll reabsorb less water that way. And osmotic diuretics, that when there is a high substance in the filtrate, and that water will also follow other dissolved solutes, so not just sodium. And so we'll talk about, when we discuss diabetes in Unit 4, that's why polyuria, so frequent urination in someone with untreated diabetes, is often common because there's a lot of sugar in the filtrate, so water will follow sugar just like it follows salt. But a diuretic increases urinary output. Urine composition, it's mostly water, solutes, and then our nitrogen-containing waste, urea, uric acid, and creatinine. We'll have trace amounts of amino acids, electrolytes, whatever we have in excess, whatever didn't get reabsorbed. We'll be looking for things that are abnormally high. And as far as volume, that has to do with your fluid intake and environmental factors. Are you exercising? Are you out in the heat? Are you sweating? We'll talk about water balance on Wednesday. Urine is usually acidic, so usually pH 6. We'll talk about specific gravity, has to do with its concentration. I'm more leaving this in here just as a reminder of things, because like I said, we'll be doing this in lab in just a minute. So specific gravity just means how concentrated it is. It's just a number value. We can look at the color of urine. I don't know if you've noticed, sometimes it's lighter, looks more like water. That means it's dilute. And other times it looks more dark in nature, and that is because it is more concentrated. And so darker. Also, drugs, vitamin supplements, and diet can also change the color of your urine. And it should always be clear and not cloudy, because that's indicative of a urinary tract infection. And your book gave you a very nice table. And like I said, we'll be doing a urine analysis shortly. And the strips, we're going to do a dipstick test, and each one of those squares gives you some information on the urine, but particularly what you don't want to see are things in this bracket, and we'll discuss what all of those mean in lab. And then I gave you a table based on what is found in the urine. It can't be in the urine unless it was first in the blood, and so it's going to kind of tell you something of what's happening with that patient. Whenever we have something in the urine, URIA, urea, is like emia. Remember, emia was in the blood, urea is in the urine, so whatever's before it. And if that's a red flag if something's unusually high, because these things are supposed to only be there in really small amounts, trace amounts, or not at all. So if they're high, there's often a pathological cause. Sometimes there's a non-pathological cause, and so that's why I gave you that table. We'll hit that when we flip to lab. All right. Oh, my song didn't come out. Oh, it's such a good song. Hello, is a key you're looking for? Yeah, we're going to edit that out for sure. Wait, have you heard that song? It's such a good song. That's all I can do. Lionel Richie, such a good song.
You don't have a bad voice. So
I'm so sad. All right, as nurses, those of you going into nursing, you will be looking for urine output, and you need to. Oh, I'm so sad. All right, Normal output, I'll show you this particular picture on the bottom on Wednesday, but urine volume is going to vary based on hydration and, like I said, body needs. So it's roughly 1 to 2 liters per day. I think I put 1.5 liters in your notes. If someone has an excessive amount of urination, so poly means many, urea means urination, so many urinations a day, so that would be more than 2.5 liters a day. It could just mean that they're really, really hydrating, so excessive water intake, or it could be something pathological, like when someone has diabetes mellitus, and because of that high glucose in the urine, water also follows. Diabetes insipidus, anyone remember what that is? What hormone? It's an imbalance. Someone doesn't have any, or very low. I know, ADH, so low ADH. Excessive of diuretics, so caffeine, alcohol, could be kidney disease. Low urine output is also a red flag. So oligo means few, so few urination. You want to take that word apart. So about 300 to 500 mils per day. Could just be someone's dehydrated. Could be that they've lost their blood volume. If you guys remember Anya, our case study, she didn't have it to give, so blood loss. Someone's losing fluids through diarrhea. Cardiogenic shock, if the heart isn't working, there's going to be a drop in blood pressure, so the body's efforts to raise blood pressures to not urinate and hold on to fluids. Clearly kidney disease, prostate gland in males, we'll look where that is. If that's increased, then males have a difficult time urinating. And then anuria, so A is without, that's really bad, that's below 50 mils, and that's kidney failure. Or there is a total blockage of urine flow, could be kidney stones, a tumor, or once again, enlarged prostate, meaning there's no urine flowing. That is a huge red flag. And 2, when you give your patients fluids, you will need to monitor their urine output to make sure you are not overloading them with fluids. So renal failure can be either acute or chronic, and so acute means sudden onset, and they classify it 3 different ways because it can happen for different reasons. So pre-renal means it has nothing to do with the kidneys, and that would be in Anya's case. Remember, she had a ruptured spleen, lost a lot of blood volume, so she didn't have it, so she was not producing urine. So blood loss, hypovolemic shock, or it could be if for some other reason there's no blood going to the kidneys. If there's no blood, there's no filtration, there's no urine. It could be just direct damage to the kidneys, so that would cause acute renal failure, either an infection, inflammation, toxin, drugs, and then it could just be the kidneys are fine, it has something to do with urine flow, and so an obstruction. So either, we'll talk about kidney stones in just a second, prostate, bladder tumor, or injury. Kidney disease can also be chronic, and the majority of it is chronic, and it's classified as renal disease when that GFR, glomerular filtration rate, is below 60 for 3 minutes. When that GFR is below 60 mils per minute for 3 months or more. And if filtrate is decreased, then urine production is usually decreased, or at least the wastes aren't being removed. And so they'll accumulate in blood. We're going to see some pH imbalances and some hormonal imbalances. We have a lot of kidney dialysis patients, a lot of people in need of kidney transplants. Our 2 big causes of this, number 1 is diabetes, and number 2 is hypertension, which we have a lot of. Diabetes just causes poor circulation. That uncontrolled diabetes has a horrible effect on the vasculature just in general. So it damages the filtration membrane. High blood pressure weakens blood vessels in the entire body, including the kidney. So treatment is going to be hemodialysis. If it gets really bad, then they need a kidney transplant. So the big thing with your patients, those that have hypertension and have diabetes, is really encourage them to manage both of those conditions. If renal disease is suspected, they will do what's called a renal clearance test, and that's just a way to measure glomerular filtration rate and the functioning of the kidneys. Also, if it's not there, it's usually going to be the glomerulus that has some sort of damage, and to follow the progression of disease. Usually what's going to be used is creatinine. Remember, that's one of our wastes. It's already there and we make creatinine based on our muscle mass. So what they'll do is first they'll draw blood, measure somebody's creatinine levels, do height and body measurements for calculations, and then they'll collect urine. Usually it's 3 days throughout the course at certain time points, and measure their creatinine and just see, are they clearing it like they should normally. Another way to do it is to add a substance. They'll add inulin through an IV, and they will give them a certain amount, and they'll see how long it takes for them to clear it. And so we'll just see what ends up in the urine. And we looked at this slide already. Because the kidneys have such a big job, there's a lot of symptoms involved with renal failure. Because they make erythropoietin, you can see anemia and shortness of breath. They're involved with fluid balance, so you're going to see swelling and edema. We'll talk about acid-base balance. You can see acidosis, alkalosis. Electrolyte imbalances, we're going to see arrhythmias. You're going to see urea in the blood because they're not doing their job. And you can either have excessive urination or too little urination, depending upon the cause of renal failure. All right, just got to urinate now. So path, just reminding you that it seems so long. These are all the pictures I could find, so I used the ones we colored. So the nephrons are out in the cortex. They are responsible for making urine, which is going to flow through the collecting ducts, out the renal papilla, in the minor calyx, in the major calyx, in the renal pelvis, ureters. We've got our storage organ, the bladder, and then out the urethra. Kind of walk our way through that. So the ureters, they are smooth muscle tubes. They have a inner mucosa, which is going to be that transitional epithelium. Remember transitional, it can stretch, okay? It's going to be moving urine through gravity and also peristalsis. So there is a smooth muscle layer. There's sort of layers of longitudinal, circular, and then longitudinal layers. And then the outer is going to be a connective tissue binding layer called an adventitia. But they are going to enter the bladder, so back, posterior, and inferior. So on the bottom right here, they're going to force urine in. They have little flaps that close to prevent urine backflow. All right, location, location, location. It's going to be different in men and women. We've got some divergence. So urinary bladder, you can find it in both sexes. So this is the pubic symphysis in both, and that organ right there, that is the bladder in women. Here is the bladder in males. Sometimes it gets confusing in the female. So this is the uterus and this is the vagina. It is a storage organ. It is retroperitoneal, so it doesn't have a peritoneum. It's going to be on that pelvic floor. And just, this would be the rectum and then the anus. And so in males, pubic symphysis, bladder, urethra, rectum, anus. So it is a storage organ. It has a transitional epithelium. It's going to be in folds called rugae. We learned that last week. It's going to have a submucosa, and then it has a smooth muscle wall, and that muscle is called the detrusor muscle. There is this triangular area right here made up, imagine a triangle, from the openings of the ureters and then the urethra. This area is clinically relevant. It doesn't have folds. It's also usually if someone's going to have a persistent bladder infection, because it's right there, that portal of entry, the urethra, that's where it's going to, that infection will be in that area. There are folds to accommodate stretch. 500 mils, so half a liter is kind of the top end of a bladder. Someone's going to start getting very uncomfortable. They'll start feeling the urge about 300 mils. 400 mils, you're going to want to go. 5, we're going to cap it at that. You're just going to go, okay? No matter how strong your will is at that point, you'll just go. We're going to look at the micturition reflex, and so this detrusor muscle is under autonomic control, so it's involuntary. Right here, where the opening of the urethra is the internal urethral sphincter. So that's where that's located. And then the part of the urethra in both male and female, where it goes through the urogenital diaphragm, so skeletal muscle, That's going to be the one that people can control once they have continence. So right there. The urethra it's also a muscular tube that's going to be the exit portal for urine. There's going to be urethral glands that are going to secrete mucus. And like I said, right here, so females, this little small strip of skeletal muscle right here where it encircles the urethra, that's the external urethral sphincter, that is voluntary. So it's skeletal muscle. So we can say, no, it's not a good time right now. Miss V is still talking. I can't go yet. She's going to want some urine from me in a few minutes, right? So you're saying no. In males, same thing. So pubic symphysis, bladder, the urethra is a bit longer, but this right here, these muscles are skeletal muscles. That's the external urethral sphincter. As far as length, you can visually see that the female urethra is much, much shorter. It's about 4 centimeters. The male urethra goes through the prostate gland. We'll talk about benign prostatic hyperplasia. Often happens in males, so an enlargement of the prostate gland, which can close off the urethra and make it difficult to urinate in males. Then the part of the male urethra that goes through that external urethral sphincter is called the membranous urethra. And then the part that goes through the penis is called the penile urethra. As far as urinary tract infections, the microorganisms are going to enter, they're going to go up the urethra. Women suffer from urinary tract infections more than men. Doesn't mean men can't get them, but you can kind of see geographically, and that it's a much shorter runway, if you will. The urethra is much shorter. Women have more UTIs than men. It's often going to be microorganisms that normally reside in the digestive tract, so from the rectum, that end up entering and going up the urethra. It can be due to improper toileting habits, also through sex. You know, things are a little messy, a little moist, so that introduces microorganisms into the urethra, either from the vagina or from the rectum. 2, if spermicides or lubricants are used, that just more fluid, more likelihood of the wrong bacteria getting in the wrong place. So urination after sex is a good idea for both genders, kind of helps flush out the urethra, also helps prevent organisms causing STIs as well. It's my public service announcement. As far as symptoms of urinary tract infection, so dys always means bad. So dysuria, painful urination, urgency, increased frequency, sometimes people don't always get a fever. They could get a fever. If it goes all the way up, because an infection can work its way up from the urethra to the bladder to the ureters, all the way up to the kidneys, and so the infection is going to get names based on location. It could be just urethritis, and so just the urethra. Cystitis, because cyst means sac, and the bladder is a sac. That's inflammation in the bladder. Pyelitis or pyelonephritis, it's telling you nephrons, that is if it's all the way up to the kidneys. So if it goes untreated, it can work its way all the way up the urinary tract system. And if the kidneys are involved, usually someone's going to have back pain as well. Not always. And then you can detect this through a urine test, urine analysis. But sometimes the urine will look cloudy. It can possibly even be blood tinged if it's really bad and extensive. Kidney stones, they are crystallized calcium, magnesium, or uric acid salts. We'll look at them in lab. They don't exactly know. Like some people tend to get them. They seem to run in families somewhat, but chronic bacterial infections, so urinary tract infections, can throw the pH off and you get crystallization. If somebody doesn't hydrate and holds on to the urine, it's more likely they're going to have higher solutes and more likely to get crystal formation and stone formation. If most stones are calcium based, so if somebody has hypercalcemia, they'll have high calcium in the urine, so they're more likely to get kidney stones. And that increase in pH, usually caused by bacteria, can also cause kidney stones. If somebody is passing a stone in that pain, they'll just say, drink a lot of water, hydration. Give them medicine for pain. There are some medications too to sort of help that pass. If it's large, they can hit it with sound waves, sonic waves, shock waves, and that will break up the stone into smaller pieces. Still needs to be passed, still very painful. And then if they're quite large, they can be removed by surgery. As far as micturition goes, and I know it's a fancy name for urination. I don't know why they didn't give you another term, but they did. Yeah, it's a combination, really. It is a sacrospinal reflex because it's going to be a spinal cord. You can see that the nerves are going to both to the detrusor. We got the detrusor involved, the internal urethral sphincter, and the external urethral sphincter. And the internal urethral sphincters, so that part of that detrusor wall, those are involuntary. So when someone doesn't have control, so let's say an infant, they'll just have a reflex. They get stretch of the detrusor, they're going to have a reflex involved, that internal urethral sphincter is going to open, and they're just going to wet their diapers. And there's no control there. When we start to gain control, the pons is also, there's a reflex center in the pons, so the brainstem. But we start getting the cerebral cortex, we can say no, right? Just say no. And it takes time for nerves and this control for those external urethral sphincters. And that's why potty training can be different. Some kids, they have that control earlier on than other children. And so sometimes it's just an age thing. If your child is having trouble potty training, just wait a little bit. Just wait. They'll be fine. And so the cerebral cortex can get involved. All right.
Neural control of urination, micturition reflex. When the bladder is full, stretch receptors in the wall of the bladder send nerve impulses to the sacral region of the spinal cord. By way of a parasympathetic response, signals return to the bladder and stimulate contraction of the muscle of the bladder and relaxation of the internal urethral sphincter. This part of the reflex is involuntary and is predominant in infants and young children. As the central nervous system matures, it acquires voluntary control over the external urethral sphincter. Urination is controlled mainly by the micturition center in the pons. This center receives sensory signals from the bladder and communicates with the cortex about the appropriateness of urinating at the moment. At times when it's not convenient to urinate, the center sends back an inhibitory signal to keep the sphincters closed and prevent voiding. When you wish to urinate, this inhibition is removed. The spinal cord instructs the muscle of the bladder to contract and the sphincters to open to let the urine out.
Okay. So, if we want to store urine, it's going to be those sympathetic stimulation that's actually, you get the urge, right? And that's when your detrusor is contracting. You kind of feel like, oh, and you can say no. Like I said, you get to say no. So that sympathetic stimulation is going to cause the detrusor then to relax for a while, right? You can kind of put it off. You can't put it off indefinitely, but for a while, you just go, all right, I can stretch. I've got Ruby. I'll stretch. It's okay. And all your sphincters are closed. So finally, though, you're going like, oh, it's going to keep sending you that message. And like I said, you can delay to a point, and then when it is time and it's convenient for you, then that's going to be parasympathetic innervation. We're going to get the detrusor contracting, the internal urethral sphincter is going to open, and then you say yes, and that external urethral sphincter opens, and then you get voiding. And there's the words for you. Say those for you. So lifespan changes, yes, everything that's supposed to do, it slowly stops doing. But yeah, the kidneys are going to, people lose kidney mass. Pretty much they lose glomeruli as they age. And so their ability to filter and create urine is going to go down. Kidneys also have an appearance, particularly if they have hypertension, they'll look extra grainy and scarred. Proteinuria, normally you should not see proteins in the urine. If you do, it should just be a trace. It's more common to see trace proteins in older people than younger people. Renal tubules are going to thicken, so it's going to be harder for that reabsorption and secretion. Everything loses elasticity, bladder holds less urine, and the big thing that happens as people age is incontinence, particularly women. Just you saw the location of it, and imagine children exiting out the vagina and just all of the stretching that occurs during labor and delivery. So incontinence is a failure of that external urethral sphincter. How do you feel about urine?
Great.
Great. Yes. All right, take your 10 minutes. Don't urinate.